Hi, I'm Zahra Khalid from Metro Health Medical Center, and today I will present I SPY differentiating an apical thrombus from myocardial scarring using multimodality imaging. Intracardiac masses comprise thrombi, tumors, vegetations, and can even be mistaken for normal anatomical variants. Factors that affect identification and differentiation include size, shape, mobility, and attachment to underlying cardiac structures. We describe a case of a persistent intracardiac apical thrombus that was camouflaged by surrounding calcified myocardial scarring on 2D transthoracic echocardiogram with echo contrast and even contrast enhanced CT scan. Eventually, this thrombus was correctly identified by using multimodality imaging. Our case is that of a 65-year-old man with history of hypertension, coronary artery disease, ischemic cardiomyopathy with an ejection fraction of 35%, history of a prior left ventricular thrombus with embolization to the superior mesenteric artery, atrial fibrillation, and pulmonary embolism, who was on long-term anticoagulation with apixaban and presented with persistent abdominal pain for 2 months. He had initially been diagnosed with diverticulitis that was complicated by colonic perforation, multiple intra-abdominal abscesses, and sepsis despite antibiotics and drainage. During this admission, cardiology was consulted for a new atrial flutter and preoperative evaluation for the resection of a newly diagnosed sigmoid tumor. A CT abdomen pelvis with intravenous contrast that had diagnosed this tumor had also noted that myocardial calcification in the left ventricular apex was seen compatible with prior myocardial infarction. A 2D transthoracic echocardiogram with echo contrast the next day did not mention an intracardiac mass. A dedicated CD chest without intravenous contrast was also completed and read by a different radiologist and also mentioned calcification in the left ventricular apex, likely because of a previous infarct. Our cardiology team performed a left heart catheterization a week after admission and noted severe two-vessel disease involving the left anterior descending and the right coronary arteries, and that the heavily calcified inferior wall of the myocardium and the calcified area in the apex could likely be a calcified mural thrombus given known left ventricular apical thrombus. A cardiac MRI the next day confirmed evidence of thrombus at the LV apex measuring 19 by 6 millimeters. And then when we went back to the non-contrast CT, as you can see in these pictures, it was easier to delineate that there was indeed a separation between the areas where the thrombus was and the calcified infarcted myocardial wall was. So the question is how to diagnose intracardiac masses accurately. 2D echo is the most common imaging modality and was used in our case initially. Other modalities that can be used to counter 2D echo's limitations are, of course, 3D echocardiogram and contrast-enhanced CT scans. Cardiac MRI remains the gold standard. The benefits of imaging are, of course, safety and a comprehensive diagnosis for preoperative evaluation. In our case, the thrombus was also noted on angiography, however, that is invasive. It is also important to evaluate intracardiac anatomy and clinical risk factors that contribute to thrombus formation. Our patient had multiple thrombotic events with risk factors of atrial fibrillation, large atrial size, and a low LV systolic function that contributed to intracardiac stasis and likely led to thrombus persisting despite anticoagulation with the apixaban. In conclusion, it is crucial to identify a persistent intracardiac source of embolus in a patient with a previously severe thromboembolic event and suspected active malignancy. Of course, every imaging modality has its limitations. Every imaging modality has its own individual technological limits. And for modalities such as echocardiogram in particular, interoperative reliability and patient cooperation is very important. Interpreter dependability also affects how precise an imaging modality may result. Our case highlights that multiple imaging modalities can be used together to help delineate and correctly identify intracardiac masses, which can be an important source of morbidity and mortality in high risk patients such as this one. Thank you.